You're fine.
Okay, I was like,
Good morning. We're gonna go live here now. We're good? And three. All right, we are live and welcome to Seinfeld this morning. We are going to discuss the abstinence. So where would we like to start? And there's no right answer. So pick a character, pick a scene.
George. Fear of this.
Here's what?
This like fear of his girlfriend's mono.
I don't think he was afraid of, right? He
But
told
yeah.
she told
Yeah.
him about the mono, and he
Yeah.
didn't seem perturbed at first, right? Like, but then she insisted that she maintain their agreement until like 6 weeks later.
Mhm.
Right.
Anything about his reaction that was inconsistent with what we might expect within a culturally sanctioned norm.
That was relatively. I mean, his like the passive aggressive, or like how long do I have to be okay with it, or is like was like
to be
yeah, like
okay, yeah.
yeah, how I'd be totally fine with this
Yeah,
or something
yeah.
like that. Right? It was like that seemed like within the norm. Like it was like obviously it's TV, but I thought it was passive aggressive, but it was funny.
A couple of things to bring up here, and it's just the way to approach behavior in general, especially when a person comes to you as a new patient with an evaluation of a particular behavior. No matter what the chief complaint is, I would strongly suggest that you take on the approach that what you're seeing is completely normal. Even when it's obviously not, train your brain to accept whatever they're presenting with as within a culturally sanctioned norm. Now, if upon their rehashing their chief complaint, all of a sudden it becomes obvious that it is in fact not normal and therefore abnormal, fine, move off that initial point. And if you do 99% of the time and you do within 2 seconds, so be it. But it's always a great approach to have unconditional positive regard. It's just a way to become a physician, even when you're going to be proven wrong 98% of the time, right? So that part doesn't matter really. And I think George's presentation to us within the abstinence reminds us of that. Now, there might be some things that come up that we think might become the object of clinical attention. And a couple of things that I think the clinician needs to be aware of is, number one, how pervasive is this behavior? Now, does anybody know there's 9 seasons of George Costanza? Anybody have a hunch as to whether or not what you identified as a little bit self-centered also being demonstrated in any of the other episodes during any of the other seasons? The answer is yes. You're not, yeah. So the answer is yes. Then if that is the case, the next question is, does that pervasive behavior result in clinically significant distress or impairment in self or others? And the answer is also yes. So even though our initial impression is exactly right, this might be normal, we do have to take into account there's further evidence of George thinking like this. And in the past, it has definitely resulted in clinically significant distress. So we might be onto something. All right. Now, for purposes of the abstinence, what else do we see happen in this subplot? That is, what happens to George?
He starts focusing on like reading and learning languages and becoming an intellect because he feels like his mind is not cloudy because he's no longer preoccupied with having sex.
Right. They use the P word, right? Preoccupied, and that's a clinical term. Somebody tell me what a preoccupation is in terms of classification. Where are we coming from when we actually use words like preoccupation?
It's a thought that's like consuming your mind and detracting focus from other things.
Right. Which may or may not be clinically significant. And again, I tend to think, knowing George as well as I know him, that it might be clinically significant, trying to keep a straight face. A preoccupation is exactly that. It is a deficit in thought content, right? Thought content here, the T, is part of the routine mental status exam. The components of which are often remembered by the acronym ABC stamp clicker. The T is thought content. Thought content we often think of two things, just trying to organize this in a little bit, part of the pun. That is the killer endings, which are suicidality and homicidality, and then the different themes, which would include, for example, a preoccupation. So that's where we're kind of fitting this observation of a preoccupation within the context of a routine mental status examination, right? Deficit in thought content. What would be the most severe deficit in thought content, albeit arbitrary within the APA? Ignoring the quote unquote killer endings, suicidality or homicidality, keeping consistent with the themes.
I'm not familiar with the themes as you're referring to them. I know you said the preoccupation was one of them. What do you mean by the themes?
Well, other variants of a preoccupation.
Okay,
Delusion.
Yeah, that's
okay.
it. Yeah, and that arbitrarily is considered to be the most severe deficit in thought content, right? The mildest deficit, which medical students tend to know less of, usually do a pretty good job in identifying the delusion as being one part of the spectrum. The opposite end of that spectrum is anchored by what is often referred to as the overvalued idea. And the reason why it's considered, albeit arbitrarily, the mildest form of thought content is because that by definition, it is not going to be clinically significant. Okay. When it actually crosses that line and it does cause clinically significant distress or impairment, we change the name. We might use the word preoccupation. We may use the word obsession, and we may even use the word rumination. Right now, those are qualitatively different, but I think for your level of training, those are largely interchangeable for your clerkship and for the shelf exam.
Am I allowed to ask about a patient, like not identifying?
Yeah.
So an example,
Yeah.
we had a patient who had beliefs that like certain medications were bad and can cause certain things. And I had a hard time distinguishing if this was a delusion or an overvalued idea. So I was trying to like read about the differences. And one thing I came across said, an overvalued idea, there may be some truth to that statement. Is that a accurate way to kind of think about if you're trying to distinguish, is this an overvalued idea versus a delusion?
That is true. I'm not so sure though, if it's a consistent or reliable distinguishing quality.
Okay.
Right. So my first question is, given this thought content, is the particular patient in clinically significant distress or are they otherwise impaired?
We were not able to like comfortably make that determination, but these overvalued ideas did at one point interrupt or influence the way he was making decisions about his medical care. So then I wasn't sure if that is, that now becomes clinically significant.
In that instance, the answer is probably yes. And
It's a delusion.
well, no, it's perhaps an obsession,
Okay.
preoccupation, and or rumination.
Okay.
Okay. Rumination tends to differentiate in that it's more about not the here and now, but about future consequences. But again, for all intents and purposes, those three terms are interchangeable. Again, the idea here is that by definition, they are clinically significant, whereas the overvalued idea is not. The example you brought up is further, I think, testimony to this idea that at any given time, and again, the mental status exam itself is just a slice of time. At any particular point in time, the individual can graduate and oscillate between one and the other. So that overvalued idea might turn into an obsession when today it is resulting in clinically significant distress. That is, they're stopping their medications and they had to be admitted for a hypertensive emergency, right? It's an obsession now, right? Once they gain a little bit of insight, they realize, wow, my blood pressure was that high and my kidneys functioned that way. They may actually then resort back to this being an overvalued idea because they get it, right? So this is not something that's etched in stone. This is something, and if you look at this, if you picture this as drawing this on a continuum, we're going to put dotted lines between these terms. Now, once, again, getting this idea of a continuum type of phenomenon, once the individual becomes rigid, that is, when despite being provided information to the contrary, they remain with this belief. And that belief is not reality-based. When you actually meet those two criteria, whatever it is that we're calling it, now is going to be relabeled a delusion. That's where it crosses the line. Right? So that intermediate terminology differentiates from that overvalued idea in that it is clinically significant. But now, not only is there clinical significance, B, not reality based, and C, rigid despite information to the contrary, allows us to relabel any of the above as a delusion, which itself can oscillate between that is a delusion and any of those intermediate terms.
So actually, I was wondering, you brought information to the contrary, so Aaron and I were talking about this, and I forgot, he said I should ask you about it at some point if I had the chance.
Uh-oh.
What constitutes, like, when do you have something that counts as information to the contrary that's sufficiently sound or valid that now if you continue to refuse to believe the thing that if you continue to believe the thing you believed before that is a delusion, when does it become a delusion, right? So I didn't articulate that very well. I have an example. So I was like,
So, and for your example, anything other than politics.
yeah, not politics.
Go for it.
Yeah, of course. It was so I mean, think about it, like people who think the moon landing was fake, right? Because you see that a lot, and I think that I have, like, objectively, I have as much evidence the moon landing actually occurred as, because I don't understand like the physics behind it. I take on faith that all the stuff that I was told is true, that it wasn't fake, right? I tend to believe that it seems hard to fake it, right? But if someone is largely, competent and not, showing other signs of altered mental status, psychosis, whatever, but there's like, I just don't think it makes any sense. Is that a delusion at that point? Like, because I am just taking on faith that information I'm being told is right, because I don't understand it on a fundamental level. So is that a delusion or not?
Yep. And I think the easy answer to this is that we have to stop thinking binary, yes or no here.
Okay.
That there is probably going to be some of this discussion in a gray area, in which we can't, one way or the other, label it neatly the way we create these artificial categories that are published in the DSM. That's
Right.
the bottom line here. But on some occasion, especially when it's causing clinically significant distress or impairment, you're gonna have to make that judgment for your patient on this particular day. And in diagnosing them or otherwise labeling them, putting a treatment plan in place to help them is really what's going to buy you one versus the other.
Right.
If we are going to call this a delusion, what does that mean? What are we going to do for the patient? And what are the expected outcomes? Because if I'm hearing, well, nothing much, then let's err on the other side, right? So the diagnostic categories and the diagnosing and labeling of people in the medical field should result in some positive outcome. And if you can't tell me there's going to be a positive outcome by doing this versus that, then let's not do this. Right. So I don't know if that's helpful.
No, it is. But yeah, it was more like that gives me a more.
Yeah. Have you seen Room 237?
No.
The documentary about the Shining.
About the Shining. No, I haven't seen it.
Oh, all right. So before you actually call anybody delusional who thinks that the moon landing was fake, just check out that documentary.
No, the thing is, I was starting to think that I wouldn't actually. They were showing other, like, that's why I think I always thought it was so ludicrous that people would think the moon landing was fake. But I thought about it and I was like, I kind of like I didn't change my opinion about whether or not I didn't think the moon landing was real or not. But I thought that you can't just immediately dismiss them as as mentally ill or delusional on that basis alone.
Now, the good news here is that on a shelf exam itself, an artificial environment, the case vignette is going to probably be able to put you in one category versus the other. Unfortunately, life is not a shelf, right? Even though, we're going to try to sell you on the fact that it is for the next 5 weeks of your life, it isn't. It's a good point, though. All right, anything else with regard to George here? So I think getting back to our original observation, in retrospect, it looks like he might be struggling with obsessive compulsive disorder, because without the obsessions of having sex with whoever he's going out with, we see a drastic personality change in his character. Now, the reasoning he gives it, or the reasoning that Jerry gives it with the head of lettuce, maybe a little too oversimplified. But in retrospect, if George's obsession with having sex or consummating relationship is resulting in his own distress, then it looks like he might be struggling with OCD. The problem here, or at least one of the presenting problems, is that I never saw George engage in any types of ritualistic acts to alleviate that anxiety that comes from the obsession, meaning that he's without any compulsions. How does that change your diagnosis? And I'll guarantee you that in any of the episodes from any of the other seasons, there is no evidence of any compulsions. And it's a trick question. It doesn't change your diagnosis. So individuals, 10 to 20% will have obsession only, or one component only. And the DSM only requires one, either obsessions and or compulsions. So the fact that George never demonstrates any compulsive behaviors, irrelevant to the diagnosis, right? So trick question, but that could come up on the shelf exam.
Is the, I know, again, I know we're overanalyzing the episodes for
For the sake of
this
academics,
discussion.
that's perfectly fine.
Yeah. So is there anything to the fact that once Jerry points out to George that his mental capabilities have increased because he stopped having sex, and then it seems to like that it increased exponentially from there? Is there some sort of like, not somatic, but like whatever the equivalent of the placebo effect is for this type of thing? Like now he's aware, and now he believes that he's getting more intelligent, so that kind of facilitates him to continue to engage in those behaviors and kind of increases his academic pursuits.
Yeah, sure thing. And I think what that demonstrates quite clearly is that even though I think most of us have been taught that when we try to understand human behavior, it's worthwhile to go through a biopsychosocial perspective. What are the biological, psychological, and social factors that are influencing the behavior? Well, when formulating a behavior and trying to make sense as to why a patient may be presenting to, let's say, a psychiatrist, it's also worthwhile to look at the 3 Ps. What predisposes to that behavior, what precipitates it, and then what perpetuates it. And for each of the 3 Ps, we could think biopsychosocially. What you're identifying are the factors that perpetuate the behavior. And the fact that Jerry and his need to believe Jerry and have Jerry like him, etc., that social variable, that friendship, would be a social perpetuating factor. So,
well, I also meant now that George had the idea that because he was, but I mean, maybe he believed Jerry because of his underlying, need for Jerry to like him and all that. But also now he believes that it's true. It's the whole, like the kind of positive outlook that helps you, facilitate some sort of behavior or do better in some task because you think that you're good at it. Is there what would be like the name for that?
well, I mean, if he's believing it and he sees a reward, right? He sees that he's smarter, whatever you want to call it. We're going to look at that within the operant conditioning paradigm. So there's a system of rewards in place here. This is reinforcement. I just talked about this yesterday with our other class, but and this again could come up on a shelf exam, when you see a behavior and you're asked what's in play, positive versus negative punishment, positive versus negative reinforcement, the first question you have to ask yourself and then look into the vignette to find that answer is, well, is the behavior being strengthened or weakened? In this case, it's being strengthened. So right off the bat, within seconds, you can look at choices A and B, positive punishment, negative punishment, cross them out. Next question is, in strengthening George's behavior, is something added or is something subtracted? In this case, it would be the addition of this new knowledge. So the prefix here would be positive, right? If something's added, we're going to call it positive. Something is actually subtracted, we're going to call it negative. So positive reinforcement would be the single best answer within operant conditioning as to what's continuing to perpetuate this behavior. So again, biopsychosocially, it's now psychological. And the part of psychology, the specific form of psychology would be operant conditioning, and even more specific would be positive reinforcement.
Could you say the thing that was being added is the Gary's, I guess, positive perception of him being more knowledgeable versus like the knowledge itself?
Yeah. It's contributing, sure. Yep. All right, so we're about 5 minutes left. Any other characters you want to discuss in the abstinence other than George Costanza?
We talked about Elaine already.
No,
Nope.
yeah.
Okay.
What's going on with Elaine?
So she kind of has the opposite reaction. I like the garbage man analogy, with the sex and everything, but she kind of seemed to have like the opposite effect, like instead of it being a strengthener and like a way for her to be more productive, it was less productive for her. And she seemed to be more obsessed, I guess, with, or more preoccupied with it.
Yeah, and it's interesting that Jerry uses the garbage analogy,
Mhm.
and I'll get to why in a second. From maybe a family therapy or dynamic model, in terms of what you identified in Elaine, what might be going on here? Because you hear, I mean, Jerry's the one who, again, through that garbage analogy, picks up on this, and there and uses it to kind of define himself, right? Even Stephen.
The idea that I guess he feels that women can choose, I guess, like they're the one, like they're the I guess the gatekeepers of like sex and stuff like that, and that he's just being used. But like in the scene where Elaine comes to Jerry's house and stuff and asks like, come on, like 11 minutes or whatever, and then he's like, you're just using me like for like you're like she's the gatekeeper, she gets to choose like when I guess men have sex, if that makes sense.
What else? What else is actually going on with Elaine? What's the consequence for Elaine?
Like frazzled and more like, so he, so her boyfriend has like failed the boards, and then she feels like she was like anxious, like more obsessive, and like it worsens her cognition.
Kind of reverts to like a childlike state, like she was like entranced by the tires and kind of like a child.
And is remind me, is was there any conversation and maybe a Jerry with commentary that one friend does well, the other friend doesn't, and there's a balance in the universe? Because he gets into that, or at least demonstrates that. Is that something you picked up on in this episode as well?
I didn't see that. I mean, I like that does come up a lot of the time, like because like there's always some theme where the opposite happens to one character, and then right, like when whatever phenomenon they describe in the Seinfeld episode, often like you see it on either ends of the spectrum for two different characters.
Yeah.
But I don't remember them doing like the balance in this episode.
Gotcha. Yep. So talk to me a bit about Elaine's relationship with her boyfriend. Who was her boyfriend? What does he do?
He's an intern,
yeah,
who failed his boards
and
3
also
times.
diagnosed
And misdiagnosed
misdiagnosed George's girlfriend with mono, probably. Yeah, seems like she was more interested in like being able to say she was dating a doctor
Mhm.
than dating that guy specifically.
Mhm.
I mean, it seems that way. It works that way.
Do you remember the when she was quizzing him, the one question he got wrong?
Metabolic alkalosis.
No,
versus hypochloremia.
it was hypoclemia, and he thought it was metabolic acidosis.
Right. Again, we only have about 2 minutes left cutting this out, but we could discuss this later in rounds, but the two actually come together for psychiatry. So when we, on our boards, when we see hypokalemia and metabolic acidosis, we'll talk about this in a little bit, but there are a couple of things within the differential that certainly psychiatrists need to know about. But we'll talk about it in more detail on rounds. Any final thoughts, any final comments on any of the characters today?
I haven't seen all the episodes, but is that lawyer character, is Kramer consistently like causing
Yeah.
him okay?
They're always in cahoots.
Yeah, but like does it always like go back like
Yeah,
does
it's
Kramer
always,
like always screw it up or
yeah,
something? Okay.
Yeah.
Kramer always finds a way.
Yeah. Yeah, and that's a nice place to end this for purposes of how Kramer's subplot does link to all things our noon case analysis, that is Creepshow. So and that's the reason why this actual episode was chosen, because of its connection with Creepshow. So what's going on with Kramer in conclusion here? How would Kramer's plot or subplot maybe be revealed on a shelf exam?
Kind of thinks that like he's being people who smoke are being ostracized and persecuted, and he's like, we're people too, and he responds to that by like banding together with all, creating a smoke lounge in his apartment.
Right.
Will be pushed to the margins of society.
Right. So brief summary, tobacco is considered to be a substance of abuse. And for any substance of abuse, it's probably a good idea to understand the substance use disorder. In this case, the diagnostic label would be tobacco use disorder. But for every substance, there's also a handful of induced disorders as well. There are basically three sets to or examples of substance-induced disorders and therefore tobacco-induced disorders. What are those three examples? Really, there's 3.5. So one would be a substance-induced intoxication. Okay, does not apply to tobacco. Right, a substance-induced withdrawal does apply to tobacco, and I think most of us have seen somebody who tried to quit cold turkey, whether within practice or perhaps in our personal lives. I don't think that's going to be difficult to identify in a shelf exam. Substance-induced mental disorders, okay, does not apply to tobacco. There are no identified tobacco-induced mental disorders, right? So there's no such thing as tobacco-induced depressive disorder, tobacco-induced psychotic disorder, 0, right? Other substances, yes. And then finally, that fourth induction example would be other, just a grab bag. Tobacco does not have anything in that grab bag category.
So that's an example of something that would be in the grab bag category.
So the only one that I know of, well, not only one of the ones that is most common is alcohol. So for an induction syndrome, something like Wernicke's-Korsakoff,
Okay,
right? Would be in that other category.
Okay.
Right. But again, does not apply to tobacco, right? So for all intents and purposes, one of the things that you should know, and I'd be able to identify in a shelf exam, is the tobacco-induced withdrawal, right? Which I don't think will be that difficult. I will say this too, just an ending, in that it looks very, very similar to cannabis withdrawal. So not necessarily remember what tobacco withdrawal looks like, but now you can remember what cannabis withdrawal looks like. It looks a lot like tobacco with additional symptoms. Okay. Any final questions? All right, we're going to log off here and log back on in about 2 minutes to our link for morning rounds. See everybody back then.
I don't find the creep show one quite yet.
what?
Pondering creep show one.
Oh, yeah.